referral hospital. I tried to engage our statisticians, and by today we had not put the data together. But we believe in the subsequent presentations, we shall have data from the Rwenzori region and then the regional referral. So early detection and treatment remains a cornerstone in management of PPH. And the WHO motive tells us the first response and treatment bundles that effectively control bleeding for women who experience PPH. We are going to go through the motive. So 60% reduction in severe PPH when you follow emotive, and about 20% reduction in mortality, and then 30% reduction in blood transfusion has been attributed to emotive. When you put it into practice, emotive, it has been found to play that role. It has reduced the maternal mortality, it has reduced the incidence of PPH, it has reduced the need for blood transfusion. And so in our presentation, we are going to go through emotive, and we want to implore that every person who is listening to us and everybody who is here gets to know the ABC of emotive.
I want to ask something.
No asking.
Not getting. They are not getting.
Who is not getting?
Those online.
The people online.
We are getting you.
Okay, thank you. Why PPH continues to be a problem in our facilities? One of them is that there's a missed or delayed diagnosis of PPH, as you can even see in the case that we have. Okay, so many times the health workers miss PPH or delay to make a diagnosis of PPH. There's also a missed or delayed treatment or intervention. Okay? Then there's also a missed or delayed escalation. You have managed PPH on the ward, you have failed to achieve what you're supposed to achieve, you have failed to stabilize the mother. What next? So these are some of the common challenges in our facilities, as you could even see from the case that we had. Okay. Yes. Next slide. So preparation for birth and preparation for PPH are key. When you get any mother, put it at the back of your mind that all mothers can be. So, and therefore it is imperative, it is important that as you prepare for birth, deliver this mother, also prepare for what? For PPH. And that's why we are emphasizing, the minister is emphasizing that every delivery room must have a PPH kit. Okay? So that you have no excuses that I did not have this, I did not have that. The PPH kit is mandatory. It is a must. It must be. If you cannot have it, if you don't have it, then don't deliver it. Send to places where they have the PPH kit and they are ready to deliver this. Next. That might not. So how do we prepare for birth? So if you prepare for birth, also prepare for what? PPH. So prepare for birth as soon as the woman is close to the second stage. Communicate to the woman and make sure the area is conducive for delivery and management of complications of delivery. Prepare for delivery and the newborn. Okay. And then we make sure we have the PPH kit in place, and then have the tonics ready to give the mother within first minute after delivery of the prepare the PPH kit and make sure that people have had drills in management of PPH. So looking at the main causes, so those are the most common causes or etiologies of PPH. One of them is atony. Okay, we talk of 3 T's, so one of them is atony or poor tone of the uterus, where the uterus fails to contract as required after delivery of baby. Then we also have retained tissues, placenta fragments and clots. We have genital tears or trauma, genital trauma, genital tears. And then we have a coagulopathy disorder. Now, you look at the case that we presented and you see where, you try to see where it falls and you, now we had tears. Where were the tears? Genital tears. Side. Okay. So prevention of PPH. So to prevent PPH, in our rooms, in the delivery rooms, in our labor wards.
To prevent postpartum hemorrhage, PPH.
So we emphasize active management of third stage of labor, what we call Amstead. And it has the following components. Okay. Yeah. So we give uterotonics in the first minute. And the most common uterotonics that we have in our centers, in our units, that is supplied by the government, is oxytocin, otherwise called pitocin. Okay. So we make sure we give that one immediately after birth. And before you give it, check whether there is a second wave. Check whether there is a second wave. There are mothers who come to us, mothers who have never attended antenatal elsewhere, and she comes to you, she's already in the second stage, delivers, and you are unaware that she has, even herself. We've delivered mothers who are unaware that they are carrying two babies. There are mothers we've taken even to theater, and we discover when we are going to theater that she has a second baby, that you have twins. Where she has prepared for one baby, she has bought clothes for one baby. So try to tease out and see whether this mother is carrying a second baby before you give oxytocin. So it is given slowly over 1 to 2 minutes. And yes, then we alternatively we can in other centers where they have heat stable carbetocin, mothers are given carbetocin 100 micrograms IM. This is in other centers that can afford it, actually some PNFPs in the country and other centers, in the government centers, where they have had funders for carbetocin, they have it. But enough this year in our facility, we do not have it. We can also give misoprostol, in case we don't have heat stable carbetocin. Because misoprostol is readily available, it's a prostaglandin analog, and we give 400 to 600 micrograms oral. Or we can even give it buccal. Okay, can use sublingual. Between 1 to 3 minutes, make sure you clamp or tie cut before. Okay, and then next slide. Perform after you cut the cord, deliver the placenta by performing controlled cord traction to deliver the placenta. You don't just hustle with it and start pulling. It is controlled cord traction placenta. Then after, make sure you perform uterine massage. Next slide. So encourage mother to empty the bladder, or else we put a catheter. So deliver the placenta. Okay, talked about that. Go to the next order of contraction. So after, check the blood, check the placenta, examine the placenta. Make sure there are no retained tissue. So make sure it is complete. Put it on a flat surface and examine it properly for completeness. Here you're excluding retained cotyledons. So if they are retained, then you know that they are retained and are going to cause PPH. They are supposed to be removed. And then perform uterine massage. Okay. Perform uterine massage and examine, check if the bleeding, the mother the bleeding is within the normal ranges. Okay. The normal ranges. In some centers, they have calibrated receivers where the mother actually, when she delivers, you make sure all the blood is received in that container, and then you measure how much blood has been. Okay. The blood the mother has lost. Check for tears, and if there are any, repair them. If you find that the tears are extensive and you need help, call the person who is skilled repairing tears and escalate the repair to theater. But minor tears, please repair them, make sure they are repaired. Continue caring for the mother and the baby. Take the vitals. Taking the vitals, preferably every 30 minutes to take the vitals of this mother for the next 2 hours before you discharge the mother to postnatal ward. Okay. Now the doctor is going to take us through the emotive part.
Thank you so much, Dr. Malemeko, for the preamble and the guidance towards the world and Uganda at large about PPH. I'm Dr. Joko, an SHO in Fort Portal Regional Referral Hospital. I'll take you through the emotive bundle. As Dr. Malemeko has said, that PPH is among the most leading maternal mortality in the world, contributing almost 40%. In Uganda, you will find that PPH is contributing between 34 to 40%. That means it is big. We need to be very careful with the controlling of mothers after birth. Basically, from the time of birth up to 42 weeks, it is PPH. We need to be very sensitive that hemorrhagic, obstetric hemorrhage, contributing 34 to 44% in the world, and in Uganda, 45% being the most leading. Obstetric hemorrhage means both APH and PPH. So if it is contributing 100%, PPH takes 85% and APH takes 15%. So the 85% which is contributed by PPH becomes the most leading among the obstructive hemorrhages. So it is why Fort Portal we chose to discuss PPH at large. And according to the Sustainable Development Goals by WHO 2015-2020, it has improved now that we are supposed to control mothers dying from PPH and other emergencies by 70 per 100,000 live births. Uganda right now, we have improved by 2016 by WHO and Uganda National Institute of Studies. We had 336 mothers dying per 100,000. So by 2022, right now, our maternal mortality rate is at, ratio is 189 mothers dying per 100,000 live births. But it's still leading, still high, because according to Standard Development Goals by 2030, our aim is to reduce mothers dying to 70 per 100,000 live births. So meaning we still have a lot to do to reach the aim of our standard developmental goals. So right now, we are looking at how better we can control bleeding. Dr. Malemeko has talked of the T's, the tears, the thrombins, and so many others. So we are also going to look at other causes apart from what we can't see. So among the emotive bundles, everybody actually here at least may have a hint It's just a reminder and to be very careful about it. Our E represents early detection. This will go to all people listening right now in different centers in the world, those in Health Center 3s, Health Center 4s, and at any other regions in Uganda. Early detection is becoming the most leading prevention of death because you'll find a clinical officer who has conducted the delivery, a midwife who has conducted the delivery, or even a doctor. If you do not detect that you have cervical tear, perineal tear, then this mother will be dying in the next 7, 6, 12 hours. Why? When you look at the rate of why we call it primary PPH, is because you have lost 500 in normal spontaneous delivery. And if you don't detect that you have tears, this mother is going to continue bleeding, even if you pack her. Packing does not stop bleeding, but will compress those vessels, those capillaries, but not blood vessels that are large. So if we have a tear and she's bleeding, she's going to continue bleeding. And in the Uganda right now we are living in, it is really very hard to take vitals every after 15 minutes as required by WHO in the first 1 hour. Then in 30 minutes for the another 2 hours. So that means these mothers, by the time we know them, they're already hemodynamically unstable. So we request kindly, if we can be very sensitive after birth to control bleeding by looking at the vulva, looking at the perineum, look at why this mother is still bleeding, because after having Amstein and you have controlled, you have delivered the baby, you have had your placenta out, you look at the mother, she's still bleeding, call for help. It is early detection. It is designed to improve the detection and initial management of PPH through a structured care bundle. Emotive aims to standardize and speed up care, ensuring that all essential interventions are administered promptly. All the steps must be done in 15 minutes. So, giving pitocin in early detection does not stop the mother bleeding from the perineum. Health workers should be very, very, very be sensitive to this. People will give pitocin 10, they add another pitocin, but the mother is still bleeding. So I think colleagues there in the world, let us now teach all other health workers how to detect cervical tears, because perineal tears may be easier to see, but cervical tears are killers today. So I've said our objective is accurate measurement of blood loss using an under buttocks calibrated drape measuring jug. At times we may not have the jugs, but we have the kidney dishes. It is very important to know the kidney dish you are with, does it have 300 mils, 500 mils, and 700 mils? Because in normal delivery, we estimate at least 500, less than 500. If you have more than 500, then you have primary PPH. So the importance is the visual estimation, often inaccurate, leading to underestimation and lead response. Our targets here are when you think that it is PPH. When do you feel that this is PPH? At times, by the time you know that it's PPH, when the mother is already asking for water to drink. By the time you know that it is PPH, when you see the mother sweating, the mother is restless, the mother is asking for the grandmother, and so on and so forth. So it is very important, this presentation, early detection. How do you know that this mother has already got PPH? It is you, the health worker, who has delivered, to estimate this. The loss of 300 mils of blood or more with the fall of blood pressure of 20 millimeters of mercury or raise of the pulse of 20. So, or more than 100 beats per minute, that is the pulse. It is actually a sign of already you have started feeling that this mother is becoming hemorrhagically unstable. So you do not wait to first deliver the mother and tell the mother stand up to see whether the mother will be able to sit or stand. But when you estimate around 300 mils of blood, it's very, very important. Then you also see your assistant taking the blood pressure, raising from maybe 110, now you have 130. That is an increment of 20 or above. It is a sign that now the body has started working to compensate for what is lost. Then if the pulse is also raising, you should also know that you are coming to danger. So loss of blood, 500 mils or more, persistent trickles, somebody is really not, actually she was talking well, now she's trickling, she's shaking, she's feeling.
Small amounts.
Yes, yes. So you're seeing the small amounts coming out, but of course you think you have managed everything. Deterioration of the mother's condition, that is what you have talked about, the sweating, the irritability. Then you start seeing the health workers start slapping mothers. Don't step on me, don't touch on me. That's when you know there's something in danger. At times you're repairing a tear, but the mother is becoming uncooperative. Please call for help. You are losing more. These mothers have started becoming hemodynamically unstable. So triggers to begin emotive, the dizziness, the confusion, the pallor. The pallor probably because the mother is bleeding, you take long to see the pallor, but look at the feet, look at the palmar pallors, look at the tongue. As she's speaking to you, at times others become so dehydrated that by the time they talk, you even see saliva getting out, and you look at the tongue. It's very important, very, very important. The excessive sweating, we have talked about it. Then atony. This is when maybe the cause is not tears and not in the perineum, but now the cause is atony. So when you have atony, you may bleed and blood is not coming out from the perineum, but blood is continually coming out from the uterus. So this is when you know, am I having the Arkwright syndrome? Am I having atony because of the thrombi? I'm not having enough clotting factors. Am I having tears that have extended up to the uterus? This is very important. You may not be bleeding here. According to our case, Dr. Manemeko has shown you that the case we received in Fort Poto, the mother is not bleeding down. And you are giving blood, the mother's abdomen is continually distending. That means, why is this mother pale, bleeding? Where is the blood going? We are transfusing. So our mother was leaking blood inside because after cesarean section, they traumatized the uterine artery and blood started leaking inside. So am I having atony? And what is the cause of the atony? Can I call for help? Put in a gynae glove? Can I remove the clots? Can I expel the membranes? Did I really look at my placenta very well? We are supposed to have around 17 to 28 lobes of the placenta. Have I examined my placenta well? Maybe I had an abrupture. So it is very, very important for the health workers for early detection of PPH. So here now, we are already giving our pitocin. Oxytocin has been given. The uterus is not contracting again. We are having loss of blood again after even giving 10, after giving 20 of oxytocin, and acceleratedly we see this mother deteriorating. Please, 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 colleagues, don't delay because mothers passing away in PPH, once a mother starts asking, I want water, she's sweating. When you take long to make a decision, these mothers die talking. Next. I'm on M now, which is the uterine massage.
O is oxytocin.
The O is the oxytocin. My M is the uterine massage. Colleagues do not know how to make better uterine massage of the uterus. Others will start getting their fingers and just putting and piercing in the uterus and inside the abdomen. Do not forget to have nerves around the umbilicus that are very sensitive. Whenever you touch on these mothers, where you think you are massaging, but you are massaging your brain. You're not massaging the uterus, you're massaging the abdomen. So it is very important, by the time you are making a massage, already the bladder is empty. Because you may be making a massage and already we are having the bladder. You're having urine inside the bladder and you're massaging the bladder. So put in a catheter. Make sure you get the fundus of the uterus. Try to hold the fundus in your palm. As you are massaging, do not press the artery, do not press the vessels around you, which we call the iliac vessels. So when you're massaging the uterus, you try to compress it, try to put it in your hands at times. You feel you are putting the uterus together and release. You hold it for 1 minute as somebody else is checking what is coming from down and then release. Because of the net wire meshes of the myometrium, the perimetrium, and the perimetrium and the serosa, they make a bundle that has to press the uterine arteries and the spiral arteries together. So once they are pressed together and you release, they will always contract. If these blood vessels do not contract and you're releasing this uterus and you're doing it between 5 to 10 minutes, that means you already have something that is beyond what you think. The technique firmly massage the uterus through the abdominal wall until it's firm and contracted. Oxytocin, we have talked about it. These days you are saying oxytocin is not working. We request the midwives and the in-charges if you can copy a leaf from Fort Regional Referral Hospital, where for us our fridge does not go off and we have a standby generator. Oxytocin has a temperature threshold. Let everybody here know that oxytocin has to be in the fridge and should have a threshold. If your fridge has been off for 30 minutes, please do not use the bit of oxytocin you have. It will give you wrong results.
Yes.
So oxytocin is the first line drug, alternatively misoprostol, 100 micrograms, or ebutamine, 0.2 micrograms that was stopped. Egometrin that was stopped, which is 0.2 milligrams, if necessary. However, as we are doing this, we are giving saline, we are repressing the lost fluids. If you give the first 10 IM, the next 10 at least should be given in normal saline. As drops are dropping, at least you make sure the 40 drops per minute in 2 hours. So you repeat, and every after 15 minutes to be checking on the vitals, that is the BP as we say. Once it is just dropping and the pulse is raising, you just know you are bleeding. Even if you are giving pitocin, the uterus has contracted, the tears will continue bleeding. Even if you give oxytocin and you have tears inside the uterus that are leaking blood outside, the BPs will fall down and the pulse will go high. And that is a sign of being a very good observant. Next. Next. The next is next slide. The T, we have this, what we call the TXA, the tranexamic acid. This one will basically actually reduce the bleeding by stabilizing the blood clots. Here, when you are bleeding, basically you are losing blood, which has both white blood cells and the platelets. So once you give tranexamic acid, basically what it does is you are going to form the the plasmin, and the clotting factor will also increase. Once you see bleeding continues that is bright red, you just know you need to increase the dosage. We can give it between 500 to 1,000 grams. So breaking down the clots, so we shall have the 1 gram, which is the 1,000 micrograms. You give it IV. So within 3 hours of PPH being diagnosed, then even secondary PPH. So you administer it early. So for over 10 minutes, you see good results. IV, we have the fluids, we have blood. Here you have to estimate what you have lost and what you are going to give. Basically, you have to understand what type of blood product you need to give when you get PPH. We have the platelets, and we also have the whole blood. So the fluids, do not give too much fluids depending on what you have lost. So basically here I want to give 1 to 2. So if I'm losing almost 300 mils and I'm going to give 2 liters, you're going to have volume overload and you're going to get pulmonary edema. And once you get pulmonary edema, you're going to cause pulmonary embolism. So at the end of the day, we may end up in failure, we may end up in ICU, which we do not have in most of our centers. So we need to be very careful when we are giving fluids. If you are giving fluids and you're not seeing any urine getting out, you need to intervene. So for the blood, basically here right now, we need whole blood. So with the whole blood, because we have both white blood cells, red blood cells, and platelets. If you can't get it, get the platelets. So the E, here we are going to examine our mother very well. And if basically identify and manage any remaining causes of bleeding. So in the examination of the placenta, whether all the lobes and the membranes are complete after delivering our placenta, the genital tract for the trauma, whether you have any tears, either apical, middle, posteriorly, or anteriorly. But at times we forget to check in the anterior fornix of the cervix, at times where tears can hide. So you either remove the tissues manually, you repair using your stitches, or manually remove the placenta if it has taken long, beyond 30 minutes. You try as much and softly and gently because it's supposed to be done under anesthesia. But if you don't have the anesthesia, we try to remove it smoothly. And monitor the BPs, the pulse, the bleeding, the atony, the output, and then give the antibiotics and make sure you record whatever you are doing. So the WHO PPH care bundles, which have the PPH emergency response, the Amstel, where we have the active management of third stage of labor. So this is a question to everybody. Can I do delivery very well? You have found out that doctors these days leave the vaginal deliveries to midwives. Can you really perform and you don't get PPH? Why are you transfusing every mother you are delivering as a doctor? Why are you transfusing every mother you are delivering as a midwife? Just know there is a problem. That's why we are presenting this. So it's just a summary of veteran of very good. After immediately having the baby getting out, you're supposed to give the oxytocin, you're supposed to give the uterotonics, you can give the transdermic acid, you can give everything, then you do the uterine massage. So immediately the placenta is out, you examine the mother, find out whether you have any tears, empty the bladder, you look at the uterus and empty everything out. If you can't repair the tears, repair them. If you can't repair, call for help. If you can't have help, please try as much as you can to make sure this mother is not bleeding anymore. You either send to theater, but it's very bad to refer if you just have tears that can be repaired easily. So for the refractory PPH, you've done all the motive and you still bleeding. So for the refractory PPH, you have done the emotive, the mother is still what? Bleeding. Are we going to theater immediately? What do? You escalate. On escalation, at times you'll find that we are going to have so many other things that we are going to do, what we call the non-conservative surgical management. So you are going to have what we call the compression. Compression, where are you going to put your hands? Where are you going to put the fixed? What are you going to do? And which arteries are you going to compress? It's normally very, very important. All of us here, colleagues, you should understand that around the uterus, laterally, we have vessels. When you put your fingers on those mothers, you will have vessels under the uterus on both sides. And there is also around the umbilicus, there's also a very big vessel that all of us expect to touch. Mostly on the right side, we shall have the inferior vena cava, and on the left side, we shall have the abdominal aorta. So normally it's very, very important to know all of that. And where do you start from? By compressing there, where we see refractory PPH interventions. Put your fist just above the fundus. You press it slowly. Make sure you look at the respiratory rate of the mother, and this mother does not stop breathing. So what you are doing, you just know you are helping blood loss. So if you are putting it there and no more blood is actually going down, just know you are controlling somehow as you are waiting for the other intervention. So you have the balloon, the uterine balloon tamponade, and there's what we call the Buckley's balloon. The Buckley's balloon is a catheter that has both a balloon inside the uterus and another balloon is in the vagina. It can accommodate roughly 500 mils inside, and you can even give 54 mils in the vagina. And basically, as you are massaging your uterus, the balloon is inside. You are trying to compress the blood vessels in the uterus with the balloon. And in that compression, they want to see whether we can have the uterus contracting. And basically, when you inflate the balloon between 250 to 500, that is what we call the Buckley's balloon. If you do not have it, others are using the condom catheters. So commonly, you will have what we call the condom catheters. You get the catheter, basically the biggest gauge you have. It can be 20 gauge catheter. Cut off the rubber band from where you insert the bag. It is at the same size of what has entered inside the uterus. So after putting the condom on, you put these two tight ligatures on the condom. And basically, when it is inside and you try to inflate with sterile water, the catheter will not slip off. Actually, you can even put in almost 500 to any other mils, between 200 and 500 mils. As the uterus stops contracting, you take some minutes, between 5 to 15 minutes. If the bleeding stops, that's when now you can try to maneuver and take out, basically. We have what we call the unshock gamut. The unshock gamut, most of you have seen it. So the unshock gamut, you'll find that it is a low-cost reversible. Reversible means reusable. You can use it and you can wash it after using and again using. Some of you have seen it in other centers when they are transferring mothers this side.
And this mother came with it.
So even the mother we are presenting had it. It is green in color. It is a low-cost reusable European compression suit. It is like a suit because it has those 5 neuroprons that you are going to be tying from the legs up to the abdomen as you're trying to compress the blood vessels. So it is designed to stabilize women suffering from severe PPH and hypovolemic shock. However, it is only applied and it has also indications. By applying the external pressure to the lower body, because you're going to compress the blood vessels, it forces blood back to the vital organs, which serves to raise the blood pressure and lowering down the pulse by having venous return. And that's how it works. So the aspects of it, it is not used to stop bleeding. You should only use the unshock garment when you have confirmed that this mother does not have bleeding and which are tears. Because repair the tears, if you do not have blood right now, put the unshock garment to be helping you for venous return as you're transferring the mother for what? For transfusion. So this mother now was referred here with the unshock garment because she did not have any tears extra that can be seen obviously. Yet the mother was bleeding intra-abdomen. So it is mostly of the first aid device used for treating hypovolemic shock, which helps in reducing maternal mortality, used in other centers, Health Center 3 and Health Center 4. Basically, it can be used to stop the gap measure for up to 48 hours only. So if you go beyond 48 hours and you have not used it, it's not most important. And it just helps to give you time for transferring the patient. Basically, you should understand that the bleeding should not be externally. You should not be seeing the bleeding from out if you're sending this mother to a referral center. The next.
You've seen that.
So you have seen that.
Talked about that.
Behind. You're going behind. Go back. Please. So we are escalating right now. We are going to look at the principal anesthetic officer as we look at the intervention as you are transferring these mothers to theater. We think our bleeding is beyond control on the ward and we need to open up. The mother is in shock. Either we have a ruptured uterus, either we have a broad ligament hematoma. Even after SVD, you can get a broad ligament hematoma, either by a precipitate labor or those health workers who are still using poor techniques, pushing the fundus when the baby is still inside. You are going to cause a rupture of the vessels, rupture of the uterus, and also abrasion of the vessels, and you get broad ligament hematoma. Let's stop doing fundal pressures. And these are the causes of why these mothers are having normal deliveries with the PPH inside the uterus and abdomen. We are pouring inside blood. So the high doses of misoprostol, at times people don't record and don't follow the protocols. So you give high doses of misoprostol because you want these mothers to deliver very fast before you go off your duty. So you find the mothers having precipitate labor, the babies are out with very bad asphyxia, but with poor outcomes. Either you have a repair, which is a 4th degree, 3rd degree, or even uterine rupture, or oxytocin. We have found doctors even giving oxytocin on previous scars, not being managed very well. You find the doctor did not know, or at times even he knew, he thought he would monitor, and mothers, and they get abruptus and get a rupture. Let's be very careful with this. Thank you so much. So we request The anesthetist will request you, Mr. Matthias, to
Yeah.
come on and help.
Yeah, thank you so much, the presenters. It has been so nice. Thank you, Dr. Juku and Dr. Maremeku, for the explanation. I hope you are hearing me very well.
You're going.
You are hearing me very well?
Yes, we are.
Yes, please.
Yeah, so as the presenters have said, so long as the mother continues to breathe, what comes in our mind is to begin resuscitation. And the following are the criteria to begin resuscitation. It doesn't mean that you wait for an anesthetist. Immediately, when you recognize persistent bleeding, put up a cannula. And what will tell you to begin resuscitation? One of them is signs of shock. There will be tachycardia, whereby the pulse rate will be greater than 100 beats per minute. Then there will be hypotension with the systolic blood pressure of less than 100 millimeters of mercury, and the diastolic blood pressure is less than 60 millimeters of mercury. Another criteria for beginning resuscitation, we are saying criteria for resuscitation while you are still on the ward or you are calling for the team. There will be narrow pulse pressure. Narrow pulse pressure is systolic blood pressure minus diastolic blood pressure. That one, it means there is poor perfusion. Then the patient will have altered mental status. Of course, there will be oliguria, and as doctor said, another criteria for resuscitation will be quantitative blood loss of more than 500 mils. So, when an anesthetist comes in, what will he consider? A patient with the PPH requires a rapid assessment and stabilization. We look at the hemodynamics. Hemodynamic status should be evaluated immediately as the patient is hypotensive due to ongoing bleeding. Vital centers, vital signs, estimated blood loss, and current hemoglobin are very, very essential. This should be assessed. Respiratory status must also be reviewed because remember, the patient we had the abdominal distension, and that's why the people realized the one who referred the patient came on oxygen, because once there's abdominal distension, then functional residual capacity is reduced, which causes tachypnea and hypoxia. Therefore, oxygen supplementation is very necessary. Next. Of course, as this patient has deteriorated, the anesthetic choice will be general anesthesia, since the patient really is unstable. And remember, this patient is at risk of aspiration. Make sure there's an energy tube. One energy tube will make sure that you're deflating the abdomen, or you are decompressing the abdomen, and drugs are given under rapid sequence induction. Intraoperatively, throughout the operation and preparation, make sure the patient has 2 lines. And we're emphasizing 16 gauge and 18 gauge. Kindly don't put a blue cannula or a yellow cannula. Then make sure work as a team. You have sent people for blood, and blood is cross-matched, is available. Continue monitoring the patient, SpO2, other vital signs, and urine output. And make sure you maintain shock index between 0.5 to 0.7. Any shock index above 1, actually when it begins to be greater than 0.9, coming to 1, that is a warning sign. Act immediately. And what is shock index? Shock index is pulse rate divided by systolic blood pressure. When you divide the pulse rate and you get the pulse rate divided by systolic blood pressure, it is 0.9 or more than, close to 1. begin acting immediately. The patient is already in shock. Don't wait. Begin resuscitating this patient. And the fluids that we give, which I recommend, are those of isotonic high crystalloids, especially normal saline and ringer's lactate. If you have blood, immediately begin. Like this patient came when he was really paper white. We had to put even blood before going to theater. 2 units. And ensure that the patient is warm. Otherwise, hypothermia kills very fast. Next. During operation, of course, these patients have, they need constant monitoring, and some end up on mechanical ventilation. Discuss with the team the mode of care postoperatively. Probably these patients, most of them end up in ICU. And make sure that you discuss, continue monitoring until the patient care is good. That is the small part I had to discuss. And within ICU, make sure early initiation of ICU bundles are immediately effected. Thank you so much.
Thank you, Principal. Thank you very much. Right. Thank you for him. He's online, he was not going to be with us. He's going for support supervision, and he was still with us, thanks to the technology. Okay, I think now we escalate to, after consideration of, we are going to theater, we're escalating to theater. So we are going to go again through the other methods that we can employ when we're in theater. Dr. Juku. So we're talking about balloon tamponade and those other mechanical methods before you decide to operate on the woman.
Thank you so much, Dr. Malemeko. Thank you, Principal, Anesthetic Officer. For those methods, now we're already in theater, and that's what we have our dear students seated here in the hall. There's what we call conservative surgical.
Yeah. First of all, look for lunch. No, I've been seeing these are professionals.
So
I know.
you can mute.
You can't be.
Now you can go for lunch. He has finished presenting. No, he's the one who mute.
He's the one to mute.
Mr. Matthias, you can mute your microphone. So continue.
I think the presenter had gone through those.
Yes.
Isn't it? Yeah, but importantly, we want to emphasize we need to be innovative. We may not have a back rib alone. Okay. For us, as he said, we can use the condom.
Condom catheter.
Yes, we can use gloves. We get a glove and tie it on the catheter and put it in the cavity, uterine cavity, and then balloon it. Okay. So we can use the glove, we can use the catheter, we can use the condom. Okay? So don't say, I don't have what to use. Be innovative. No, questions are later. Keep your questions. I know they are burning you. Keep the questions. So let's go to the next. I just wanted to emphasize another one on what we call bimanual uterine compression. Bimanual uterine compression, you get your fist here and go through the vagina. Go to the posterior part of the vagina, so the posterior part of the vagina. Then get your uterus, the other left hand, if you are left-handed. The other hand remains on the fundus, and then compress the uterus in between these two. The hand which is on the fundus, and then the fist, and then you compress there. That's called bimanual uterine. Yes. Okay, we're going inside and then out. So we can do that, and then if that fails, of course, we do it intermittently. That fails, then here we are going now. We are going to, in addition, it is in addition to the other mechanical methods. Then now here we are going to the surgical methods.
So you can take off from there, Dr. Duko.
Thank you so much, Dr. Malemeko. So we are in theater. There's a lot that is going to happen in theater. Number one, immediately you open, you inspect the abdomen. If it was a normal delivery, and at times these mothers had previous incisions, you will find the incision sites of the previous delivery already gaped. You will find already clots of blood in the abdomen. You will find the previous incisions open. So the management of that is open up the uterus. After cleansing and cleaning the abdomen, open up the uterus, lavage it, clean out the clots and the membranes, suture or trim the previous incision site, and suture it again. You ask for pitocin or oxytocin and make sure you leave the abdomen where the uterus has contracted. Number two, this mother has delivered by cesarean section. She's not bleeding through perineal tears because she did not deliver, she did not push, or the baby did not descend, but through the vagina. But the abdomen is full of blood. The uterus can give you, and the perineum down vaginally, minimal bleeding, but the vitals are unrecordable. The mother is hemodynamically unstable. So when bleeding is inside the abdomen, when you open this abdomen, make sure all colleagues, you open these abdomens in the sumi incisions. That is sub-umbilical midline incision, to expressively explore and see what is inside. You will find clots, and you will find ligament, broad ligament hematomas at times.
So you deliver the uterus.
You deliver the uterus out, do not repair from inside.
Deliver and explore.
So you explore and remove the blood at times to see where the bleeding is coming from. If we have been doing this within 2 to 6 hours to 3 hours, you can save the uterus. There's what we call conservative management to spare fertility. When you are sparing fertility to a mother that was now a prime gravida, now a para one, and a senior surgeon has entered the theater, we try as much as we can to spare fertility by not doing a subtotal hysterectomy. So you explore where bleeding is coming from, and is what we call the Oli suture. Oli suture. L-E, it is capital O, an apostrophe, L-E-A-R-Y. The vessels, the uterine vessels ascend. Is it okay? When they are ascending, at times they are both sides. So we ligate the uterine arteries bilaterally by the Oli suture. You get where the surgeon maybe have damage, you repair where the surgeon had damaged the vessel, then you ligate the vessels 3 centimeters down your scar on the left and the right. After ligating these arteries, that means at times you just see uterus contracting, bleeding has stopped, we are reducing bleeding upwards. The mother started saying, where I am, the mother started, the blood pressure starts raising, the pulse rate starts reducing. That means the RAS has been helped. The renin-angiotensin system now is back to play. So if you cannot use, if you enter and the hematoma, the broad hematoma has devastated the whole broad hematoma, even going behind to the round ligament, such uterus are very hard to save. For my senior, like Dr. Malemeko, as he teaches, he says, save a life. As you are going to save a life, this mother is hemodynamically unstable. This mother is dying. The BPs we have 50 out of 30. Immediately we enter, we allocate where the bleeding is coming from, try as much as we can to identify the uterine arteries on both what? on both sides, identify the lower segment of the uterus, and start doing what we call the subtotal hysterectomy. For the subtotal hysterectomy is only done when you have nothing to do. This is the last resort. But previously, if you can't save this mother, there are still other sutures you can use. If you have atony, you have ligated the ligament, the uterine arteries, you can use a B Lynch. What is a B Lynch suture? It is both, when you look at the uterus, you're creating two breasts, both sides. That's what I call at times to me as a breast suture. You go near where you see the incision site, go through it, down, make sure you start from in front, not behind, because behind we have so many blood vessels that you can prick, but you also have a position where the lower segment behind may stop. So you go through one side from down where you had your incision site up to behind posteriorly. This is where you prick almost like 1 centimeter. The lower segment, do not put it in the posterior, in the upper segment. You go where in the lower segment, you prick on the side where there are no vessels, then you make sure it is so tight and put it on the other side and then come back in front. So that looping over and coming back in front makes that uterus become so to compress the endometrium, so that the bleeding, the vessels are compressed to form contracted uterus, and also the vessels to contract. So that if we can have the spiral arteries to be controlled, no more bleeding, you have ligated uterine arteries, this uterus will be like a ball, a small ball. That means you have compressed it very well, and you have to be patient, between 5 to 10 minutes inside the theater, the uterus has contracted. If it does not contract, having thrombin problems, again it will become atonic, even after putting your B Lynch. So that's when you are supposed to say, I think this has failed. If it has failed, do not go to a subtotal. There's what we call the Hemorrhage stitches. The Hemorrhage stitches are long. You can put them longitudinally and transversally. They are going round. When we go to what we call the co-square sutures, the co-square sutures are like a box. You go longitudinal and transverse where you see bleeding under the muscle, because at times this uterus may be atonic, but because of your poor technique, the uterus was pulled out very fast. So you damage the layers of the endometrium. So you are bleeding under the uterus. So what do? We put what we call the co-square sutures, where you see bleeding under, you put those stitches, then it stops. You just go down, laterally, up, left, right, and you close up. So when all fails, you have put the Hemorrhage stitches, you have put the bilateral uterine stitches, and you have ligated the uterine arteries, you have put the square stitches, you have put the building stitches. That's when we start now thinking of the last option of a subtotal hysterectomy. At times, it is very important, we need to be very careful. Mothers that have had obstructed labor, where this presenting part of the baby was a head and has been engaged, at times even at station 0. We have the old technique of saying, you go for the legs, let the midwife push the baby down. We are causing cervical tears. And after repairing your uterus, you are not bleeding inside the abdomen, you are very comfortable, you take back the mother to the ward. You are going to see bleeding from down. For you to rush the mother back to theater, you enter the abdomen, there is no bleeding. The uterus is contracted. You were rough. You caused a cervical tear on a mother that you took to theater. So we are no longer putting hands down, pull the head, and so on and so forth. We are gently delivering these mothers. That's why the new technique of SOP, before we do any cesarean section, we are doing vaginal toileting. And that's when we do not want your fingers inside these birth canals because you are pushing the heads back. You do the birth toilet, vaginal toileting, you clean even the head, if the head is there, very well with your disinfectant. So that when you are inside the abdomen, you gently deliver that baby in a breech presentation. When you deliver the baby in the breech presentation, at times the breech extraction, you can even extend your incision to a J incision. What is the J incision? Becomes presenteric and you extend it slowly up so that when you go for the legs, you do not damage the blood vessels. So we need to be very careful. When do we get bleeding and tears after a cesarean section? It can occur. Can we get PPH when we are not bleeding down but bleeding in the abdomen? We have also seen the scenarios. It can also do what? Occur. So the most important thing was our early detection. So we have what we call the uterine and utero-ovarian artery ligament. Irrigation. So that one, after ligating the uterine arteries, you go down in the ovarian ligament where you are going to find the ovarian artery and vessels. Ligate them also. So when ligate them, you have ligated the uterine arteries down also, you are comfortably okay. So can you please also look at what we call those techniques for high, like ligating the internal iliac vessels, that's the artery. Is it okay? Not done by everybody and not done from everywhere. You're supposed to have a very good what? Very good team. So who will look at the abdomen, bleeding is coming, but we expect at times when we like get these arteries, we can save the mother. So you go in, but not go in for the ureter. So make sure it is really the artery you want to ligate, but not the ureter. So after looking for it and ligating it and bleeding, and you have taken out even at times even the uterus, but the mother is still bleeding from the stomach. At times we do what we call a total abdominal hysterectomy. The next slide. So we have talked about the total and subtotal.
So in some centers, they do total, or if you have the time, you can do the total. But if you don't have the time, like what we do in most of our centers, we do the subtotal. It saves time, it is quicker than the total, okay? But if you have the time and the mother is now a little stable, what is recommended? Actually, in the developed countries, they don't do subtotal, they do total. In our case, we did subtotal and we do subtotal and save the mother. I think that is the end. That's the end. Thank you for listening. A few maybe remarks or corrections. One, I apologize. We are sorry. We should have started with the definition of PPH, but in our slides, we thought it was going to come alongside emotive, and we did bring it out. Yes. That more than it is no longer, don't wait for 500 meals, around 300. Because if you wait for 500, the mother who came, probably some of our mothers come with HB around 8. If you say you are waiting for 500 to make a diagnosis, she will be there. So around 300 begins managing PPH. And so we put the definition somewhere, it is somewhere along. But also to add on that is that if the mother's condition deteriorates, because I know most of us, it is difficult in our settings to measure blood that has been lost. So if you see the mother's condition deteriorating, think of PPH. You don't lose anything if you begin managing PPH, but you lose a lot if you hesitate. The other important thing is now this mother we manage. I just want to bring this to our notice that the center where she was managed to do a subtotal. And they gave us a reason which I thought I should bring here, and I don't know whether it is reason enough, that in that center, it is not allowed to do subtotal. It is not allowed even to do BTL, because the mothers there get incentives by having so many babies. And this team, they had also a language barrier. They could only speak Swahili and a foreign language. And so the history was picked from a bit of hustling here and there, Swahili, and then we called back. One of the specialists called back, called the doctor, that center, and he's the one actually who said he could not do, yes, it was a rupture, very difficult to repair, and he could not do a subtotal for that reason. That we are yet to find out whether it is real. And if that is going to continue going on, then we might lose mothers. They can't do a subtotal because there is an incentive for having more babies. Yeah, I think that's what I have to say. But the doctor was willing and gave us a lot of information, and we went in very sure of nearly what we were going to get. But thank God we saved this mother. So I thank you for listening. I hope we've given something, we've learned something, students and everybody here. So I now invite their comments online. So in conclusion, innovative is a strategy that brings promising approach to managing PPH, and everybody we should embrace it. All of us who deliver and those who intend to deliver. We should standardize care and then prompt interventions which are done to reduce maternal mortality and morbidity, and then improve outcomes in our facilities and worldwide. Then let us commit to implementing this strategy in our practices and work together to save lives. Yeah, I wish to thank the team that has presented, those online and those present here. I also wish to thank all of you who have attended, and wish to invite any compliments, corrections, submissions from those online and those in here. Our doctors, interns, and the students who are here, you are encouraged to ask something or compliment. Tell us what you think you've liked and what you've not liked. Tell us what you think we have left behind and we should have told you. And then we have questions already. Okay, questions. Okay, we begin with those online. Okay. There are questions. Mine is here and then see the questions.
Hello.
Hello.
Hello. Yeah,
Hello.
mine is about supplementing on what has gone well. We are emphasizing that uterine tonics are oxytocin, heat stable carbetocin, and misoprostol.
Yeah.
We are emphasizing that TXA is not a tonic and is only used for treatment of PPH, not for prevention. Number 3, we are saying that we should monitor our patients. When we are monitoring, we should document the vital signs and record, but we should know also how to interpret them. You'll find that in a certain center, there is where they were monitoring, they monitored the mother till death and reported, I'm no longer recording any BP, I'm not recording any pulse rate. So where possible, let's record and interpret, and where possible, report the findings. 4th, the temporizing measures that the doctor explained very well to stop bleeding, such as aortic compression, UBT, and rest, are performed until appropriate care is available, like what Dr. Juko has just explained, those subtotal, like the arterial ligation and rest. Otherwise, thank you so much. These are the supplements I wanted to give. Thank you so much.
Thank you very much.
Okay, thank you, coordinator, and thank you, team MCH, for the presentation. It has been a very good presentation. Dr. Melameko, thank you for organizing this. I just wanted to point out a few issues. One is that whoever is online should know that PPH is a monster, and at all times, we should be prepared for PPH. We cannot tell which mother is going to develop PPH. And as a result, in all our facilities, for those of us who are online, we must make sure that in all our facilities, we should have availability of a skilled attendant at birth. And that skilled attendant at birth should at all times anticipate and be prepared to manage PPH. And that's why at the Ministry of Health, we advocate so much for every unit to have a PPH kit. Having a PPH kit makes it easy for anyone managing a mother when they develop PPH to access all the required items for management of PPH. For the students, you should take keen interest to know what is in the PPH kit. And as a rule, we expect that in every facility, at all times, we should be available. And I've always talked about availability as the cardinal principle. Availability of the health worker. Availability of somebody who is going to manage PPH. Let's be on duty so that we can be able to recognize that the mother has had PPH. Number 2. Then number 3, we should be able to respond that the mother has had what? PPH. So apart from emotive, we have the acronym of 4 R's. We have the 4 R's. The first R stands for a readily available skilled attendant. 2, this skilled attendant should be able to recognize the symptoms that were mentioned. That's the second R. And the third R, you should be able to respond and respond appropriately. Each one of them has constituents, so some things that you need to handle. For example, in response, we expect that you will require help and you will consult appropriately, and also you should be able to know your limits. Okay, that is very, very important. And the other thing is that you should be able to request for help. For example, we have brought in the anesthetist. Most times when we get PPH, we should be able to call on other people, and involving other specialties tends to give better outcomes for mothers who have had what? Who have had PPH. So, and the last R, the fourth R is reporting. You know, documenting everything that has, what you have done, what you have seen, what you have done, and what has come out. It's very, very important in the management of PPH. Now, the other things that I just wanted to touch on are, what are the predisposing factors to PPH in the labor suit? Okay, there are those that we have academically known before, but there are some practices in the labor suit that predispose mothers to PPH. For example, fundal pressure. You know, I have found students and midwives applying fundal pressure. Fundal pressure is inappropriate, it's very wrong, it can predispose the uterus to a rupture. also interfere with the uterine contraction after delivery. Massaging the uterus before the placenta is out is not appropriate. That tends to predispose mothers to and then cease during delivery of the placenta. You know, taking the cord up and down around 90 degrees, up and down. We say a sustained downward
Okay. Dr. Una. Doctor, we are not getting you well.
Doctor, your network.
You're traveling. We can, I think we can go to him later. Yeah, probably he's going to write some of them, but they are key. Important thing, 4R, make sure you note the 4R, that's an acronym. And then the bad practices that the health workers, the skilled health workers can also predispose the mother to PPH. And that practice of hitting that fund operation, actually, it even ruptures the spleen. On top of rupturing uterus, it ruptures the spleen. It can also cause tears, lateral tears in the broad ligament. Okay, so it is a bad practice that we should not embrace. We should stop. Are there others online? Then we come to the house. There is a comment online.
There was a question online. Someone asked, was saying National Medical Store supplies capitocin, but its uptake is zero at the facility where he or she works. His concern was like, what is its action? How can you compare it with oxytocin? And was asking, can it also be used in the management of PPH? That was his or her question in the message. However, even those still having questions online, the gap is still open for you to raise your hand and then ask those questions.
You want to answer capitocin?
Yes. Heat stable capitocin is equally effective as oxytocin.
Yeah.
It's good to be used, or they are supplying it in those facilities that may not be able to have constant power supply. So it's good to use them in those facilities and is equally effective as oxytocin. So you should not fear to use it. And it's used for prevention of PPH. For prevention of PPH, that is, it is role. So if your facility is not taking it up, fearing its action or effectiveness, please start using it. It is very effective.
Thank you. Then the Kemgisa Grace is saying, in a situation where we don't have calibrated jazz, big great help of what? Blood loss. So I don't know.
Be great of great help, blood loss.
So Kemgisa is saying, in a situation where we don't have calibrated, can suction machines with calibrated jazz be of great help in blood loss estimation?
Okay, yeah. We are saying we are encouraging people to be innovative. If you say we are going to wait for calibrated drapes, personally, I have not even seen it. Not seen it in photo. I don't know whether there's anybody who has seen it in the region. Yeah? So we need to be innovative. There were other traditional methods of measuring, estimating blood loss, and Dr. Juku alluded to them. In labor ward, we can use the kidney dish. We can use the kidney dish. We can use, there used to be jars. I don't know whether we still have jars, but you can use these common jars, measuring jars. Okay. Then for those who have suction, I don't know how many have even a suction machine, suction in labor ward, but in theater we have it. So we can use it in a theater, whereby you first make sure the light one is out, and then you estimate how blood you suction, how much blood you suction in the suction. Yes, so suction machine can be of help.
Yes, thank you. Actually, this, when you read the ACOG, emphasizes calibrated jazz.
Yeah.
But when you use the essentials of maternal and the, which we use like in Uganda,
Yes.
it is actually exactly what is our consultant is what is emphasizing. So in settings whereby we have resource setting, you may not be getting that calibrated jazz, but you can use the kidney dishes really to estimate that. I think that question has been what attended to.
So we can go to those in the room here. So there has been a correction that, again, Dr. Timothy has said it. Apetocin is for prevention. Okay. Anything in the room?
Maybe. Hello.
Yes, yes.
Oh, thank you very much. I would like to first of all thank the team very much for presenting and giving us such a very enlightening presentation, and also thank the team over there, Dr. Malemeko, for how you handled that case and having saved the mother. We really appreciate. Now, a lot has been said already. I'll just add a voice to what the HOD mentioned, Dr. Una, on among the 4 R's, request for help. Normally with PPH, it's being such a big matter and something that requires decisiveness, it's important. We used to say back then, before even the emotive bundle, that has now helped us make things easier, always call for help. As a doctor, learn, or someone working in the obstetric unit, learn to work in teams. Upon recognizing a mother being in PPH, it's important to call for help immediately. Do not try to perform any heroics alone, because you will need extra hands. In some facilities, as a matter of fact, we used to have even a bell available. Upon detecting PPH, we ring or we sound the alarm to let the whole unit know that closer attention is needed in this. So I would really advise my colleagues, those that are working in the labor ward, obstetrics unit, to always call for help. No matter how simple you think, you might have pulled out in 2-3 cases or even 10, but there will always be that one case which will cause you more trouble. So always ask for help. And even when recording or reporting, it's important that in your report, it's well documented that you worked as a team. And by that way, I believe we shall be in position to save more mothers using the emotive strategy. Thank you very much, team, for the work well done and also the presentation. I really appreciate. Thank you.
Dr. Kolot is our very own. Thank you very much. I don't know where you are, but thank you very much. Whether you are near or far, we appreciate your input. You had. Okay. Next, is there any other?
No.
There's Rugumayo. Is Rugumayo there? Rugumayo is our very own.
Yes, Rugumayo, we are listening to you.
Hello, thanks very much, team, for that webinar. We've learned a lot, and from that scenario, but mine is to re-echo on the side of the anesthesia team that choosing the right technique is very important. And whenever they call us that there is PPH, let us think of choosing GA vis-a-vis spinal, leaving other factors constant, because you don't know, maybe the patient at that moment is compensating. Then secondly, still in line with PPH, is the use of the tranexamic acid, of which it has been abused by MyCADA. But again, we have passed a resolution where we say that let us have our tranexamic acid off our usual trays of anesthesia, such that we don't accidentally pick it and give it intrathecally. And again, we do give it when PPH has occurred. So strictly tranexamic acid should be given by when we are treating PPH. Most of us have been giving it as a prophylactic drug, which is very wrong and a waste. So let us adhere to the new guidelines, whereby we are strictly saying that tranexamic acid should be administered for treatment and within 3 hours following vaginal birth. Thank you very much.
Well, thank you, Sir Gumayo, our very own anesthetist in the region. Thank you very much for the contribution. I think we go to the, we are now,
we are coming to the audience.
The audience.
We shall first see who are those going to ask questions. Then at the end, I think we shall answer, the consultant, the team will answer at once. Yes.
Yes.
Thank you very much, the team for a wonderful presentation. I have about 3 or 4 questions. But first is an appreciation for a wonderful presentation. And among the 4 areas, there is one that has
skipped your mind.
Yes, and that is responding appropriately and as well as knowing your limits. Because oftentimes you find you are an MO, personally I'm a medical officer, and you find you're the only one on duty and you really try to do everything within your means to save the mother. But then again, you have to call for help. So about knowing my limits as a medical officer, do I go ahead to do the subtotal, or mine is stop at doing uterine arterial ligation as well as utero-ovarian arterial ligation, and then maybe I can call for help. Then next, another question. That was the first question. Then another question is about the condom catheter usage. For how long do I expect results? After how much time do I say now this has failed? Let me step up. Then the time interval still goes for by manual uterine compression. For how long should that take? After how much time should I say that now this has failed? Let me step up. Thank you very much.
Another question?
Thank you for the point. Another question?
Hand behind.
Intern doctors? Midwives?
There's a hand behind. Yes.
Thank you so much. Personally, gained a lot. Especially the consideration on the use of TXT for postpartum hemorrhage. Because I had this controversy that the obstetric population responds differently to TXT than the surgical population. And I was still wondering whether there is sufficient evidence that even when I use that TXT in PPH, without, because we are trying to escalate and use all the other bundles, and we're using them concurrently. But you find in the probably lower level facilities, you just only have oxytocin and then TXT, and you're thinking a modest way to reach the viral site. How possible is it that we are going to obtain in the obstetric population the importance of TXA in arresting that PPH, but vis-a-vis the surgical cases?
Okay, next. Another question. Students, other students, interns and workers, where are they? Walimbo is not here. Wambale, Tracy, Dylan, we are here. Okay, we can go with those and call it a day. No, you are asking, okay.
So I have like 2 questions. When you compare these 2 guidelines, the essentials of maternal and child health, and then ACOG. ACOG in our guidelines says that routine use of TXA is not what? Is not recommended. But when you see the guideline of ACOG, it is highly what? Emphasized within, as one of the doctor hinted about it, within the 3 hours post SVD. Then the other thing is one of the investigation, the other question is one of the investigations which are needed. As in the essentials of maternal emphasizes baseline like CBC, so you can do the blood levels, but when you see ACOG, you realize that it is either emphasizes monitoring of fibrinogen, because fibrinogen within what? This. So on that, how can you talk about those two different? Because they are like not up, they are like opposite to each other. This one, I was saying that TXA, it's not routine. ACOG says it's a what? It is you give. Then investigations is not fibrinogen is not a must to monitor, but ACOG says you must what? Monitor fibrinogen what? Levels during this what condition. So I want some light on those.
Okay, I think let me answer those and give you that. Because some of the questions are tricky, especially on TXA. I want to begin by answering that. Hey, we want to answer it. Okay, you're going to answer TXA. The limits of a medical officer. Now, in Uganda, the medical officers are deployed up to health center 4. And the president made a campaign in the campaign that we are going to deploy them even up to the center. Okay? And then among the other duties that I may not mention, the other duty and the noble one is handling MCH, obstetric matters, actually. Obstetric matters. Any medical officer who does not handle obstetric matters, the community will put you in another category that you are not a doctor. Because any other category of people can handle the malaria and so on and so forth. So you are put in a health center 4 to handle emergencies and obstetric emergencies. Okay? That's one of the main things. And maternal mortality is about, it's an indicator about the level of care of a country. Okay? About the level of care of a country. So, and that is the reason why they want, they are skilled people that we need to put at that level. Hand in hand with midwives. So, the issue of saying you are alone, no, you don't work alone, you are working with the midwives. That one is out. You can't be alone, you have midwives and other categories of people. You'll even have an intern. Every health center 4 has a midwife at a level of diploma and above. This there is. You might have 1 or 2. Then even other categories who are capable of managing mothers. So you are not working alone as per the policy of the government. If you find that you are alone at a center and you're in charge, I think you have a right to complain to the service commission of the district that you need manpower. Then managing PPH. When you are managing PPH, you have said, don't manage alone. Call for one. Okay. The moment you recognize that it is PPH, you call for one. Mm-hmm. Why do you call for help? There are many things that you are going to do, and they are done in a short time. And if they are not done in a short time, you will lose the money. Even when we go to theater, what he has been talking about, all those maneuvers, if you've been to theater, you think every minute of what to do. You have done this, that's failed. When to do it? This man, one time he said he didn't know how I thought about certain thing. You're thinking like, I'm not saying a mad person, but here and there. You put a village, watch, 10, 5, 10, 15 minutes has not worked. Say, no, I think something different. You go to another thing until you think of removing it. So you are doing things in a limited, short of time. And so you need help. If you don't have help, then you'll be losing money. Limitations. So interns, when you're an intern, when you're a medical officer, you go through a number of steps of training. Okay? And at the level of now it was 3rd year when you're exposed to all these conditions. They begin telling you, go to the ward so that you see, you begin seeing. Then in 5th year, you begin like touching. Touch, you're assisting, now you become an intern. When you become an intern, now we take you through. And we believe by the time you leave internship, you should be able to handle most of the emergencies. And we have said the commonest emergency is what? So we expect you to know the level of handling PPA up to the level of subtotal. Irrigating the uterine arteries is simpler. Matter of knowing the anatomy, as you say, yeah. So that one you cannot. No one will blame you if you did, for example, subtotal, and you are saving a woman. No one will blame you as long as you save her. It is probably we can put some bit of blame. You are doing a subtotal, as it happened in some cases, and you have tied the urethra. Say, probably the training was not. You may need a bit of retraining. Okay? But we, as seniors, we guard against us. We make sure we really teach you the basic, the best. So limitation of PPH, probably the other advanced things are looking for the ilia, on the internal ilia, and so forth and so forth. And the ureters up there, you may not. But we are saying, if you can do the basic up to the subtotal, you can save up to 99%. Beginning with the emotive and the rest, and so that is it. But you realize that there are areas who cannot even, the medical officers who cannot do it. And then the question is, you ask yourself, where did they do the internship? And we structure the internship in a way that you go through the surgical and then so, but those outliers are there, those who just go through it, beat the system, and they move with a swagger, and eventually, this is what we tell you, that it catches up with you in the community. You will find the community burning even your house, because you cannot even save a man, you cannot deliver a mother, do a simple delivery. So it is high time that now we have students here that you need to learn when you're here. Don't come and WhatsApp here or look at only your girlfriends and then you go away in your intern. So there's a lot to learn. It's good. You attend these things and then you know the burden that we have. It is a lion. PPH is the lion in Lebanon. It's the lion in the community. Okay? You want to answer TXA, but first of all, we are not working for the surgeons have their own studies, as you say. The obstetric patients, the population is different from the surgical population. Okay? Yeah, surgical, they are different. There's quite a lot of physiological changes that go on in these mothers. And then so I know in somebody bleeding in surgery, they are giving TXA. I know, but for us, we are saying, no, we have protocols, teams, people sit down and they've done studies. WHO has done studies. Akol Gazi has done studies. And so they come up with protocols, and the country, as I've always emphasized, looks through those protocols and picks what is feasible for the country, what we can manage, okay, in terms of resources and manpower, and in terms of training, okay. And so the country picks what. And so when the country says this is the policy, don't say now I am going to use a call. So the national guidelines are saying we are using tranexamic acid for treatment. And that's it. And within 3 hours. If it is secondary PPH for after 24 hours, no. So the research has been done. If you give, for example, there are studies which show that if you give tranexamic acid before you deliver baby, from its mode of action, remember it causes clots, eh? So it is going to cause microclots in the placenta. What are you going to get? You're going to get hypoxia of the baby, and you're going to get fetal distress. Okay. Now, a surgical patient, is he pregnant? Is he carrying a baby? So those are different populations. Okay. Right. Any other thing you want to add on?
Thank you so much, Mr. Manabu, for the presentation. Sister, do you have anything we use for practical? If you have anything, please, for PPH, this is the best time to have the practical session for PPH. We shall need them.
We shall be making drills, I think.
Yes. However, I will thank the team for being present. You can clap for yourselves. According to the new guidelines of ACORD 2024 about PPH, we have all the drugs we are talking about, the tranexamic acid, the carbopros, which is the compressing, and the oxytocin, and the rest. So the tranexamic acid being an analog, which is anti-fibrinolytic agent, is it okay? It has receptor sites in 3 positions. Number 1, it has GABA receptors, it has glycine receptors, and it also has which other receptors? Plasmin. It comes and binds to plasmin, which prevents the breakdown of red blood cells to form what? Form clots. So we want those clots to remain inside. We do not want the breakdown, which is called fibrinolysis. So when you get fibrin, you are going to break down the red blood cells into clots, and they will start getting out. Sorry, you don't form the clots, you now start getting fibrin. That means you are going to lose a lot of blood. So when you give tranexamic acid, it binds on the plasmin and then prevents formation of, it binds on plasminogen, it prevents it to break down into plasmin and clots. So it does not prevent PPH by constricting blood vessels and contracting the uterus. It only works on those smooth muscles, and plasmin itself has to be present. If these people have thrombin deficiencies, even if you give tranexamic acid, these matters are going to bleed more. So that's why doctor is telling you the mechanism of action. It has to be within 10 minutes. If the problem was in the uterus and you have atrophy and you have given tranexamic acid, within 10 what? You should be seeing a difference. That's why they give you, when you give through the vessel, between 5 to 10 minutes, you should be seeing a change. If blood was fibrinolysis with plasmin out and you give tranexamic acid, the uterus will contract, then you start seeing clots. Then the uterus will stop contracting. If not contracting, think of something else. Don't use tranexamic acid as a substitute of oxytocin. Unless when there's something else.
Thank you, Doctor. We are about to close. One had forgotten. The man asked us about monitoring fibrinogen. It just goes back to what I said, that the country picks the policies, the protocols are there, and the country picks what it can afford. Now, you realize what percentage of mothers deliver in rural Uganda? 80%, isn't it? 80%. It's only about 20% that are in urban. Okay. Now the question is, ask yourself, if they deliver in rural Uganda, by place there, Mirami, somewhere, Kasese there, do we have the facilities for monitoring fibrinogen? I doubt if even we have it here. I don't know. I am yet to ask the lab. And I am yet to ask the physicians. Those of you who went through internal medicine, are we able to monitor that? So certain things that we are not able to monitor, we improvise and pick what we are able to. I believe it is very costly. So the government cannot manage, we can't manage. And so we can, with what we put in place, the protocols that we put in place, we have also done, we've done local studies and they are working, we are saving the majority of the mothers. And that's why we are emphasizing, we are now emphasizing some things that are cheap, that we can do within our means, immortal. And we said it has reduced death by 80%. So that's what we are emphasizing. Probably in other centers, I know those centers that they can do all those monitoring, fibrinogen and whatever. Other centers in Kampala, they can do. Not many, like 2, 3. So we are emphasizing in rural Uganda. We shouldn't go that way. I just want to bring one other aspect. I one time got a referral, and the mother had a septic abortion. Mother has septic abortion, with sepsis, you hemorrhage, she developed jaundice. The center referred, and they referred because of the referral was because of jaundice. Now, when I called back and they wanted to discuss with the team there, the doctor was cross on me. He said, "We don't do liver function here." So I sent for evacuation and liver function. I said, it would have been appropriate if you evacuated. It would have been gentle and more probably would understand it better. And then you say, okay, I am. Then, like you were discussing, but in me at the end of it, I knew that probably that person did not know other causes of jaundice. So I cooled down and handled it. But so you can see. So we are not saying don't evacuate because somebody has jaundice. Don't evacuate because somebody has anemia. We say evacuate, then manage complication. See that? So somebody will twist it. So that comes with that we have protocols, and the protocol is we are going to treat, we are going to manage without monitoring fibrinogen, and we shall still save as many as we can. Thank you very much. I wish to call it to a conclusion that you put some, I think we go offline. Is it possible? Go offline.
Yes,
and yes, we remain in-house and we ask other